All right. Good evening, everyone, and welcome to one and all. As you all aware, OCI has 4 specialty interest groups on Facebook in clinical optometry, binocular vision, dispensing optics, and low vision. A team of 4 members for each specialty were nominated by a panel of experts to form the core team of SIG based on their experience and expertise in the field. Today, we have a session curated exclusively for our binocular vision group members. It's a first session on this group, and for this, I would like to invite Mr. Diwakar Rao to talk on vision therapy hierarchy and techniques. Mr. Diwakar is graduated in optometry with honors from the Lotus College of Optometry in year 2007, and he completed his post-graduation in 2012. He is currently working as a HOD and Associate Professor of Vittala College of Optometry, Vittala International Institute of Ophthalmology. He is teaching and training undergraduate students of optometry from 2011. He is specialized in vision therapy. Welcome, Mr. Diwakar.
Thank you.
Yes, today we have Ms. Namrata and Ms. Nikita in panel. So Ms. Namrata has completed her graduation and post-graduation in optometry from Manipal College of Allied Health Sciences. She pursued her fellowship in pediatric optometry from Sankara Nethralaya, Chennai. She is currently placed at the Sankara College of Optometry, Bangalore as a head of the department and pursuing her PhD in the field of pediatric optometry. Welcome, Namrata.
Thank you.
Joining her today in panel, we have Ms. Nikita Jacob. Nikita completed her graduation from Sankara College of Optometry and Masters from Chitkara University. She works as an assistant professor at Sankara College of Optometry and consultant optometrist at Sankara Eye Hospital. She is pursuing her fellowship in vision therapy from ASCO, India. So, welcome, Nikita.
Thank you.
Okay, welcome all. Without wasting much time, I would like to invite Mr. Diwakar for his talk on vision therapy hierarchies and techniques.
Thank you,
Mr.
Ashita.
Diwakar, over to you. Yeah.
Thank you. Thank you, Ashita. And on the outset, I'd like to thank the Optometry Council of India taking this initiative and starting this special binocular vision group. And this is going to be the first topic of this group. I'm very excited to take up this topic. And let me start with this session for today. That's vision therapy, hierarchy, and techniques. So hierarchy, I'm going to talk about if you find any binocular vision anomalies, how do we start from the first? What will be the first management of this patient? And how do we go further in a given case? So types of vision therapy plans are goal-based or grid-based or diagnostic-based. Goal-based are the one which achieves on sensory fusion and work on smooth pursuit movement, whereas grid-based are specific set of activities in developmental sequence and each activity for a specific duration of treatment length. Diagnostic-based are based on differential diagnostic treatments. For each case, it will be considered as separate, like example, convergence insufficiency or convergence excess, whereas compared to accommodative insufficiency or esophoria or esotropia. So we have different diagnostic-based plans. Consideration in vision therapy, what should we consider is first is the visual diagnosis. What category or what syndrome under this binocular vision anomalies comes under, and available training equipments which can be used for therapy, the goal of the patient as well as the guardian related goals, the hierarchy level of procedure from where we can start, how do we go about, and it should be affect and attitude of the patient has to be analyzed, and comfort of the patient, and it has to be performed as well as seated as well as in the standing activities. So more consideration is we have to do activities, even though we are doing it in a virtual based platforms, we have to include the experience of the patient in the real performance because after the therapy, the patient is going to live in the real space. So we have to get the patient, even though we are giving computer-based or virtual therapies, we have to train the patient in a real space. In-office therapies, which requires emphasis on many other visual skills, and also the optometric vision therapy activities, which are incorporated in also the several other categories. And we also have to include loading and unloading. Loading and unloading is increasing the difficulty as well as decreasing the difficulties of therapy. Some of the aspects of vision therapy is work on oculomotor. So this is very primary aspect. First thing what we look in vision therapy, work on or improvise on fixations, pursuits and saccades. Then in accommodation, work on accuracy, amplitude, and the facility. And also next, check on anti-suppression trainings, monocular fixation in the binocular field, that is MFBF. Then developing sensory fusions and improving on the fusional range extension. Then visual integration, followed with that sensory motor integration and sensory integration. So these are all the aspects of vision therapy. Coming to the oculomotor, when we talk about oculomotor, what all we have to work on? Work on developing accurate fixation skills, developing on accurate pursuits and saccades, integrate oculomotor skills with accurate motor response, then integrate oculomotor skills with the sensory skills. Then vergence and accommodation system has to be integrated, and also the visual information processing has to be integrated with the oculomotor skills. This is with oculomotor dysfunction. If you find any subjects or any patients with oculomotor dysfunction, this is how you start going to the further steps. And accommodative dysfunctions or any patients with accommodative dysfunctions, first try to normalize their amplitude, then make sure that they are able to sustain that amplitude, then work on improving the ranges, that is relaxing and stimulating the accommodation, then normalize the facility of the patient, the speed at which you can relax and stimulate. Then not only accommodation, also start working on vergence to interact between the accommodation and vergence, and interact between the visual information processing. Any patients with binocular vision anomalies, for those patients, oculomotor control and accommodation has to be normalized first, then work on suppression, then develop adequate fusional ranges and vergence facility, the speed at which you can converge and diverge, then normalize the depth, that is stereopsis, then the interaction between accommodation and convergence has to be performed, then integrate the visual information processing. Patients with amblyopia, so a lot of us, we think that just visual acuity improving is sufficient enough. No, as a lot of informations have proven that visual acuity is just a tip of an iceberg. You have much more depth in the problem. First, work on centralizing the foveal fixation. So you can check through visuoscopy and find out is there an eccentric fixation or not. If there is an eccentric fixation, first work on that. Next, normalize visual acuity. Then work on oculomotor and accommodative functions. Then develop accurate spatial localization. Then binocular alignment and functions has to be done. And then decrease the suppression if the patient has a suppression. Most of us will just improve the visual acuity and stop there. If you don't integrate the oculomotor, accommodation, and binocular function together, there are chances that visual acuity will regress back. So this is what happens with most of the cases with patching therapy. The one with the patching therapy, the visual acuity will improve. But once you're not integrating the accommodation and vergence together binocularly, there are chances that the visual acuity can deteriorate back in the amblyopic eye. Strabismic cases, work on oculomotor control, then spatial localization, normalize the accommodative abilities, eliminate sensory adaptations like ARC if the patient has anomalous retinal correspondence, work on that, establish sensory fusion, develop accurate fusional ranges, then vergence facility, the speed to which you can converge and diverge, then normalize the stereopsis, then integrate between accommodation and convergence. So what are the loading and unloading we can do throughout the therapy? Gross motor, that is when you're working on gross motor therapies. To increase the difficulty, you can make the patient to lie down or sit down, then hand and knees, you can, and standing you can do. But decreasing, you can work on jumping first, then balance beam, then walking, then balance board, then standing, and last go towards sitting and lying down. Environmental aspects, what you can decrease the difficulties, initially work on private room, a quiet space, a dark room, clutter-free where there are no distractions. Slowly you want to increase the difficulty, take it to a group space where a lot of other therapies are happening. Then background noise is also introduced and music is introduced. And there are background clutters can be introduced over a period of time. Couple of loading and unloadings which can be done with the target time and also the cognitive auditory, that is lenses can be used. Increasing difficulties by increasing training lens power, you can go to the higher dioptric power. Minus lenses or with base-ins can be used for divergence, and plus lenses and base out for convergence training. To decrease the difficulty, initially what you can do is compensatory lenses can be used, like added lenses what we use. Then decrease the training lens power. Then minus lenses base out prisms for convergence, then plus lenses base in for divergence. So let me take through a case over here. This is a 35-year-old lady who is a bank employee. Chief complaint is eye pain on reading for longer hours since 1 month. History of computer use 5 to 6 hours per day. The best corrected visual acuity is plano 6.6 N6 in both the eyes. Anterior segment findings are within normal limits and posterior segment findings are within normal limits. So we did a binocular vision assessment for this patient. A cover test was ortho for distance and near. AC by ratio is 4:1. That's within the normal limits. NPC is 5 centimeters with a break and 7 centimeters of recovery. That both subjective and objective. NPC with a pen light, that's a non-accommodative target, was same 5 centimeters and 7 centimeter, and it doesn't recede when you repeatedly do near point of convergence. Near point of accommodation is 9.5 centimeters and in right eye and 10 centimeters in the left eye. When you convert that into an amplitude, it is 11 diopters and 10 diopters. Binocularly, it is 12.5 diopters. MEM plus 0.25 in both the eyes. NRA is plus 1.75 and PRA is minus 1.25. So what we have to look over here is NRA and PRA values, the normative value is 2.5 and PRA is minus 2.5. Here you find both are less than the normal limits. And amplitude, the minimum amplitude for that age should have been 6.8, but the patient has around 10 and 11 diopters. That is good enough. The further evaluation was performed, and we did negative fusion convergence and positive fusion convergence test, NFE and PFEs. And we got the values like blur, break, and recovery. For distance, for negative fusion convergence was X, 8, and 6 in prism diopters. And for near, it was blur was not noticed, so that's why X. Break is 12 and recovery is 8 in prism diopters. Positive fusion convergence is blur is no blur noticed, and break is 20 and 24 is the recovery. Whereas with respect to negative fusion versions, positive fusion versions for near, blur is not recorded and break is 30 and 36. So these are the normal comments, and Virgin's facility was 18 cycles per minute. Accommodative facility with right eye 3 cycles, left eye 4 cycles, and OU 3 cycles per minute. Patient was having difficulty with both the lenses here, difficulty in plus as well as minus. So plus lenses will relax accommodation, minus lenses will stimulate accommodation. The patient had difficulty with both plus and minus over here. So the abnormal findings in this slide is, you see the accommodative facilities are on the lower side. So the important findings, what we see is amplitude or near point of accommodation was a normal. Facility fails, so the patient had difficulty with both plus and minus. MEM findings were normal, plus 0.25 in both the eyes. NRA, PRA, in that PRA was low, that's on the lower side. So minus lenses is, even NRA you saw, it was on the lower side. A patient had difficulty in relaxing and stimulating the accommodation. So the diagnosis of this by looking at all those parameters, so we come to the conclusion that this is a case of accommodative infacility, where the patient had difficulty in relaxing and stimulating the accommodation. So symptoms of these patients, usually they complain of focusing difficulties. They cannot focus for distance or near. They will complain of asthenopia symptoms, difficulty with attention and concentration, intermittent blur with near task. This is what they commonly complain. Management of accommodative infacility, correction of ametropia, added lens and vision therapy. These are the common option. But here the added lenses would not be a good option. If they have any refractive error, you correct it. But this patient was having plano 6/6 N6 for both the eyes. So hence there is no refractive error correction. But vision therapy was appropriate for this patient. So hence we will talk about vision therapy management for this case. How did we manage this patient? So management of accommodative anomalies. In that we are talking about accommodative infacility case. In general, accommodative cases first work the feel-like ability for the accommodation on demand, normalize the accommodative amplitude. In this case, you saw the amplitudes were normal. Sustain accommodation, we have to work on sustainability. Range of accommodation was poor here, we have to improve on range. Facility was poor in this case, so we have to normalize the facility. And then once that is done, we have to interact between accommodation and convergence relationship. Okay. So in this case, we started off with improving the amplitude and facility by giving this red rock exercise. How does this work? I'll just explain you through a video. So you will have a red-green anaglyphs to be used and a flipper to be used. And you have slides which are matched. And patient is supposed to wear a red-green glasses. And you are asked the patient to use a flipper. So there are words which are there on the slide, and patient has to identify the similar word which is matching to it and keep it on the slide and continue this each time. And each time when you're placing the word, when you're finding the new word, you have to flip it. So on this flipper, you have one side a plus lens and other side a minus lens. So plus lenses will relax your accommodation and minus lenses will stimulate your accommodation. So you're working on relaxing and stimulating both. So we're working on amplitude as well as on the facility. A second, what we can do is we can introduce an HART chart. HART chart is a distance chart and a near chart is there, which we can fix it on the wall at a 10 feet distance. And you give a near chart at an arm's length and the distance chart is fixed on the wall. And patient is supposed to read small letters on the near chart and then look at the far to relax the accommodation. So let me go through this video. This is a near chart, and that's a far chart which is fixed on the wall. So patient is looking at the near chart and stimulate the accommodation. Look at the far chart and relax the accommodation. Patient is holding a chart at an arm's length, and you're able to see reading a letter by letter, or you can ask them to read horizontal one line and the second horizontal line at the far, then vertical line for near, and then vertical line for far. So you can give an alteration over here. Then you can keep on adding the level of difficulties over here, like we have discussed about loading and unloading. So you can introduce plus lenses, minus lenses in front of the eyes, and we can continue the therapy with this. Then we can use lens sorting. So this is to relax and also stimulate the accommodation. We can use this. The equipments needed are, you require uncut lenses of plus and minus, and you require a accommodating hopping card. So how does this work? So you have lenses which are kept in different dioptric bars. You ask the patient to look through those lenses. If it is a plus lens, you'll relax the accommodation and find out the task on each side on the this card. There is a task is there, and they have to supposed to do that. And once it is done for the one eye, you can also perform it on the other eye. You can ask the patient to occlude one eye, or you can put a patch on the one eye and you can perform this therapy. So this is lens sorting. And you'll see as you go to the higher dioptric bar, you have to relax more. And as you go to the lower dioptric bar, you have to relax less. So you start with the lower dioptric bar and then go to the higher ones. Same way, you can also use minus lenses to stimulate accommodation. Loose lens rock to restore normal accommodative amplitude and facility you can use. You can use loose uncut lenses, and hopping card can be used. Then accommodative facility, this is the speed to relax and stimulate accommodation. You require accommodative flipper, and also you require a hopping card. And this is the hopping card, and here the subject is holding a flipper. This is a plus or minus 2 diopter flipper. You can start with the lower dioptric bar and then go on to the higher dioptric flipper. And you can ask the subject to relax and stimulate the accommodation. So they can read each word one by one, and plus lenses will relax and minus lenses will stimulate accommodation. So this is accommodative facility, which can be used as also therapeutic purpose. You start with the lower dioptric bar and then go to the higher dioptric bars. So lower is like, it's available with 0.5, 0.75, 1 diopter, 1.25, like that. You can go up to 2 diopters. Then we can also use computerized therapy for accommodation. So here we can see the computerized therapy is being performed. The patient is asked to look through the flipper, and patient is wearing a red-green anaglyph glasses, and they are supposed to match the words which are there, one on the top row and one at the bottom row. So one is seen through one lens, another one is seen through another lens. So you are stimulating and relaxing over here by using these flippers and using this word matching therapy. Okay, so similarly, you can introduce a lot of other therapies in accommodation over here. So this was a case of an accommodative in-facility, what we discussed till now. And those were the therapies which can be used. And the next set of second case, which I'm going to talk here. So this is a 27-year-old male who had come to our clinic. History of IT professional, complaint of headache, a bitemporal headache. History of headache decreases with break from the computer. No history of nausea or vomiting associated. History of using glasses from past 1 year and did not change since then. and no history of any specific ocular or general health history, and no history of underlying any medication or not aware of any allergies. So this was the findings. PGP, the patient was using 0.5 diopter cylinder, axis 180 in the right eye. Vision was 6.6 N6. In the left eye, -1 cylinder, axis 180. Vision was 6.6 and N6. Retinoscopy showed right eye plano and left eye -1 cylinder. Acceptance was plano in the right eye and left eye -1 diopter cylinder. Both the eyes visual acuity were 6.6 N6 with this correction. Slit lamp examination was normal in most of the findings, were normal in both right eye and left eye. Dilated fundus examination was also normal in this case. Patient was advised to undergo binocular vision evaluation before the dilatation process. So we did a binocular vision assessment. Rutherford dot tests were performed and fusion for distance and near. Stereopsis was 40 seconds of arc. EOM was full free painless. Cover test showed exophoria for distance and near. The amount of exophoria for distance was 2 prisms basin, and for near it was 10 prisms of basin. AC by ratio was 4:1. NPC with accommodative target was 12 centimeters was the break, and 17 was the recovery, and it was receding. And with red filter, it was 17 centimeters and 25 centimeters. It was also receding. NPA with right eye 10.5 centimeters, amplitude was 9.5 diopters. Left eye 10 diopters of amplitude. Binocularly was 12 diopters of amplitude. NRA was plus 1.75, PRA minus 2.75, and MEM was minus 0.5 and minus 0.25. NFV X6 and 4, blur, break, and recovery for negative fusion emergence. Negative fusion emergence for near was X18 and 16. This is what we are checking divergence. Positive fusion emergence when you're checking convergence was X6 and 4, and for near X8 and 4. And accommodative facility with a plus or minus 2 diopter flipper was 6 cycles per minute in right eye, 6.5 cycles per minute in left eye, slow with plus, and binocularly you can see it is 3 cycles per minute and difficulty with plus. And Virgin's facility with a plus or with a 3 diopters basin and 12 diopter basin flipper, and we found it is 3 cycles per minute, difficulty with base out. So diagnosis, before we diagnose, we look at the all the findings over here. I have taken out only the findings which were abnormal. You can see exophoria, which the patient had for near. It was 10 prisms basin, which is outside the normal limits. So the normal values are 6 as a normal. And you can see NPC was showing 12 to 17 centimeters break and recover. It is much higher than the normal limits of 3 centimeters to 5 centimeters. And NFV was normal in this case. The PFV was the abnormal findings. So look at this PFV findings. X6 and 4, the normative findings are 19 and 10. And here for near, it is 8 and 4. The normatives are 21 and 11. So it's much lower. NRA with plus lens was low, PRA was with the normals. And look at MEM. MEM is the normatives are between plus 0.25 to 0.75. But in this case, it was showing on the minus side. So that means you're stimulating your accommodation more. And binocular accommodative facility was 3 cycles, where the normatives are like 8 cycles per minute. And Virgin's facility was also affected here in this case. So these are all the findings which are showing abnormal. So by looking at these findings, the diagnosis of this case was convergence insufficiency. So how did we come to this convergence insufficiency as a, so in this case, if you see the distance phoria was low, the near phoria was high. So in case where the near phoria, exophoria is high, so that comes under convergence insufficiency. Another way, you can also see the direct test NPC PFE was low, Vergence facility was low, AC by A is supposed to be low. Here it was 4:1. The indirect tests like MEM, NRA, and binocular accommodative facility were also affected. So hence, it is not a case of divergence excess or basic exophoria. It clearly confirms it's a case of a convergence insufficiency. So how did we manage this case? The general criteria to manage these patients with convergence abilities are lenses, prisms, and vision therapy can be used. In this case, the first option would be to correct any ametropia is there. As this patient had plano in right eye and -1 cylinder in left eye, needs to be corrected. Over that, vision therapy would be the first option of management here. Then the prisms can be used as a secondary management option. And how did we manage in this case? If you go through the hierarchy first work on oculomotor, then work on suppression, then improve the ranges of convergence, because in this patient, the convergence was difficult. Then work on vergence facility, improve the base out values, then normalize the stereopsis. Now coordinate between accommodation and convergence needs to be done. So in this case, we started off with a Marston ball, where we started working on ocular motility, where we asked the subject to look at the target, and when it is coming, and they're supposed to use the fist or the arm to push the ball. Later on, slowly we'll go to the thumb and ask them to push the ball with the thumb. Then ask the subject to start holding the ball by using the palm without using the fingers, then by using the fist, and slowly you can ask them to do with the crutches. That's with the tip of the finger. And then you can start working on increasing the difficulty by giving them a command to use the palm to hold it or use the fist to hold it. So you can just inform them in between when you're doing the therapy, so that they'll be attentive enough. And so that's how you work on ocular motility. Then work on improving pursuits and saccades. Here you can use a flow rotator is being used, and you ask the subject to place the pecs inside the given target. And once they have started performing, it starts improving their eye-hand coordination, as well as the pursuits and saccadic movements can be improvised with this. Then work on Brockstring to improve the ranges on the convergence and divergence. First, normalize the NPC values, then go for the bigger to the smaller size. Then first touch the bead and then shift the fixation. Then get the beads to closer by the inches. Then take out the beads and ask the subject to look like a bug on the bead, and then remove the string, and you can do them voluntarily converge and do it. For that, you have to explain the patient first about physiological diplopia, because this works on the principle of physiological diplopia. How does an A pattern look like? How does a V pattern look like? And how does an X pattern look like? Then we can use vectograms and work on improving the fusional ranges, which we can improve their fusion ranges to even up to 30, 35, even 40 prisms of fusion ranges can be improved. So then we can also use tranoglyphs. You have variable tranoglyphs and non-variable tranoglyphs can be used, and improving their convergence ability up to 30 to 35 prisms of convergence. Here we require a red-green glasses to be performed. And then we can also use computerized therapies to improving their convergence by giving it targets on the screen. And along with that, we can use septum and apertures to work. This will be a higher level of difficulty. We can use Binocular and aperture ruler and ask the subject to look through the Binocular and converge, and also use the aperture rule, and then you can converge. And you can use the home-based therapies which can be used at home, which can be prescribed to the patient at home. So thank you for once again, all of you, for patiently listening to this topic. And if you have any queries, you can get back to us. And post this talk, we will have a panel discussion with our panel team. Namrata and Nikita have joined us, and we'll go ahead with that.
Yes, I would like to invite Nikita and Namrata for the panel discussion. Okay, basically right now, first of all, thank you, Mr. Divakar, for the enlightening talk. Cases, what you took, they were the wonderful example, because that's what we see more commonly nowadays. Still, many practitioners don't practice vision therapy, and they refer to ophthalmologist without doing any test or taking care of the symptoms or anything else. So what would be your advice to the young practitioners? Why should we incorporate vision therapy in our practice, basically?
Right. Even if you're not practicing vision therapy, the minimum battery of tests, if you can perform, that will be really good to find out at least if they have any anomalies. So those minimum batteries of tests which can be performed are, say, for Fourier, if you can measure with a Maddox rod or a Thornton chart. If you don't have a Thornton chart, in your trial set, at least you will have a Maddox rod. So just find out, is the Fouriers are within the normal limits. So the normal limits for near is up to 6 to 8 exophoria if they have. No esophoria should be there. So that is one simple test you can perform. The next is near point of convergence. Near point of convergence, get a target close to the eyes and find out if they find any double, or if you're seeing objectively if the eyes is getting deviated. And the normative values are 3 to 5 centimeters. That is 3 centimeters is the break value, and recovery around 5 centimeters. If you see anything more than like 10, 15 centimeters, in this case, we saw it's around 12 centimeters was the break value. So if you can do that as one simple test, which you require just a near vision chart is sufficient to do it at your clinical based. Then near point of accommodation, if you can perform a simple test, bring the target close to the eyes and find out where it gets blurred. And you can compare that with the Hofstadter's formula. And for accommodation, one small test I can recommend is accommodative flipper. If you can have a +or -2 accommodative flipper with you and perform a monocular accommodative facility, speed at which you can relax and stimulate the accommodation. These 3 to 4 minimum batteries of tests, if you can find out, because NPC will talk about your versions, how it is working. Fouriers will talk about your Fouriers under normal binocular conditions. Then monocular accommodative facility is good enough to rule out if you have any accommodative insufficiency or accommodative excess. You'll come to know, are you having difficulty with plus lens or a minus lens? These minimum batteries of tests which can be included. Then if you find it, anything is abnormal and you are not able to manage that patient, you can recommend that patient for the specified vision therapy clinic, which can be managed well. Or if you find these findings are normal, then can be an other associated anomalies which can be ruled out, like patient may have a small amount of vertical Fouriers, or the patient may have anisoconia, which can be because of anisometropia, or it can be a fusional versions dysfunction. In those can be identified binocularly, that you can refer to the further management. I want Nikita or Namrata can add up on this if I missed out anything.
Very rightly said, sir. So, when it comes to management, or when it comes to the importance of binocular vision investigation and vision therapy in our day-to-day practice, just as Divakar sir rightly said, the minimum test battery is a key thing that is going to help you in assessing the patient and understanding if the patient has any binocular vision disorder. If you feel the entire assessment is time consuming, then at least these minimum tests would do. And there are also studies which says that prevalence of binocular vision anomalies are more as compared to refractive error, which means many patients not referred to binocular vision assessment or vision therapy is not because the prevalence is less, but because the right assessment is not done. So this drives us to the importance that when we assess the patient, every patient walking into our clinic, when we assess them at the right time, at least an early diagnosis would help us in diagnosing the patient earlier and treating them and managing them in the right manner as well. Because every person walking into your clinic with a history of blurring of vision or double vision is not only because of refractive error. So that gives us the importance of why binocular vision has to be assessed in our day-to-day practice, and how vision therapy plays an important role. Namrata ma'am, would you like to add something as well?
Yeah, just to continue with both of your thought process. As an early practitioner, what everybody thinks is how much do I need to invest on in my clinic? So when it comes to vision therapy, you don't need to invest a huge amount. Not really that you have to start with a big software or any software. You can start with simple your trial set and a ruler and few targets which is required for evaluation as well as for your therapies. So for beginners, we would always recommend you don't even need to invest on huge instruments which are required. Even the flippers or the facilities can be done using just your trial lenses. You can use your trial lenses to check the facility, or the prisms which are there in the trial set can be used so that you can complete the assessment with just the simple trial set, ruler, and the targets, near targets and distance targets, which you can just take a printout on your simple papers, and you can start with your evaluation and therapies. Even to create a broad string, you don't need to require any bigger targets as such. You just need a thread and beads and you can give therapies. So a major message is, yes, as both of them rightly said, the evaluation does not require a complete evaluation in the beginning. It is just with the entrance test or simple battery of tests we can start with, and then if required, we can refer them for the full evaluation. And also to start the clinic, it's always a simple test can be included and simple tools can be involved, which is available in the clinic, so that you can start today with the binocular vision practice.
That's right. Thank you so much, all. There are questions on the Facebook basically. So what are some therapies we can give to relax accommodation in cases of accommodative excess?
Right.
Yeah.
Okay. Yeah. So these patients will have difficulty with plus lenses to relax. So the ideally is first, most of these cases would have been an accommodative excess case where they will be finding difficulty with plus lenses. So you can use therapies like what we have discussed in this presentation. We can use HART chart can be used, a simple therapy tool which can be used. You just require a printout of a distance chart and a near chart. You can stick it this chart at a 10 feet distance, that is 3 meter distance, and ask the patient to look at the far chart and then look at the near chart. Sometimes the patient will have even not access to these. A simple exercise, what I tell some of the patients is stand close to the window, and on the window grill, you can put a small newspaper cutting, which is, it can be printed of available of N8 font or so on a newspaper grill. On your window grill, you can stick it that and look outside the window and look at the farthest object, what you can see, probably a a name board or a nameplate or something which is available across the road. And you can relax your accommodation when you look far. And when you look at near a window grill, you can stimulate your accommodation. So it works like an HART chart. The other therapies which can be used is the lens sorting. So you have trial sets in your clinics. You can make the patient to sit down and give the trial set lenses, and you can just close those numberings available like plus lens, 1 diopter, 2 diopter. You just block it with a tape and give it to the patient to identify which is the higher power and which is a lower power, and ask them to arrange it in an ascending order or a descending order. So it works on relaxing the accommodation. Or another therapy which I missed out here was plus lens build-up exercise, where we can give a near target, and on your trial frame, you can put a plus lenses with a start with a plus 0.5 diopter or a 0.25 diopter. Ask them to read the reading material. Then increase that plus to 0.5, 0.75, keep on increasing. Still, they can relax the accommodation, and over a period of time, you can keep on increasing. So these are the very simple exercises which you can incorporate to relax the accommodation in a clinical based therapy. Or if they're not able to come, if the patient is in a remote place, a HART chart would be better. Even though if you don't have a HART chart access, you can do the simple exercise standing near the window and you can perform the therapy. Yeah. Namrata or Harshad, Nikita, you have any points to add?
I would also like to add, as Sir rightly said, the patient is not going to accept plus lenses. So when it comes to our refractive correction, when we find out that the patient is having more towards a hyperopic shift plus correction, the patient is not going to basically accept those glasses when you don't give vision therapy. So when you are planning to give the correction, the proper correction to the patient, and it is towards the plus, the patient is, you're going to have a troubleshoot, and the patient is going to definitely come back to your clinic saying, I'm not comfortable with the glasses. So it's always ideal to give the correction, along with it, start vision therapy. Without vision therapy, without relaxing their accommodation, the patient is not going to accept the plus lens, or we'll have to give the plus correction very slowly if the patient is very symptomatic. So that's all I would like to add on to what he says.
Yeah, I would like to ask Ms. Namrata that if we are giving any home exercises, so, especially to the kids, so compliance is a major factor in the vision therapy. So how do you motivate them, to do the exercises at home also?
So we can always ask them to take a video and upload us on day-to-day basis. This is one of the things which we can actually think of from the parents' part of it. Also, in terms of home therapy, we do have certain games which are exclusively developed for kids or for pediatric patients. So we can incorporate that into the home therapy, so that children compliance is much better as compared to other part of it. So those, because indirectly we can also track their compliance while seeing for their performance through the vision therapy, which are given over the digital, any of the digital screen mode.
That's right. Yeah, great suggestions. There is one more question on the FB. Can you share more on pursuits and saccades training using different techniques in your practice? And do you think patients having accommodative anomalies also need pursuits and saccades training to some extent?
Yeah, the simpler techniques which you can incorporate for saccades and pursuits in your clinic is using a HART chart. One we discussed is the near HART chart. You also have a peripheral HART chart, which you can have 4 more charts which can be put in the periphery of the main chart, and ask the patient to look at from one chart to another chart. So you're changing your fixation from one point to another point. So that works on the saccadic and pursuits. If you have a simple Marston ball, if you don't have that, you can create your own Marston ball. We do that of many of the patients. You get the smiley balls, so you can buy that one and you can put these numbers or the stickers, alphabet stickers on that, and you can tie it to your ceiling. And you can move this ball like what I have shown in the therapy. We can use that. Or we can also do it in a horizontal pendular movement and as well as the vertical pendular movement. So this will work on pursuits and saccades. First work on monocularly and then work on binocular pursuits and saccades. The question asked for accommodative anomalies also does need pursuits and saccades. Yes. So any binocular vision anomaly, it can be an accommodative anomaly or a vergence or even an ocular motility anomaly. First, we have to work on pursuits and saccades, improving the ocular motility first. If that is better or if that is normalized, then we can go for the next therapies. That is what the whole presentation was about, the hierarchy of therapies. First always comes is oculomotor therapy, that is working on pursuits and saccades. Then go to the specific conditions of therapy. If this question is asked and even in amblyopes, yes, even in amblyopes also, work on oculomotor first, then working on improving the visual acuity.
Okay, thank you so much. There are a few more questions. What are some key points to remember while carrying out binocular vision assessment for a keratoconus patient? Ms. Nikita, would you like to answer?
Actually, the keratoconus patient is an entirely different scenario. It is, beyond binocular vision assessment or something. It's about the clarity of vision is affected. There is the anterior segment that is affected in this patient. The cornea is affected in this patient. So, the mode of management for this patient would be very much different, because the clarity itself is poor. So I think it's beyond accommodation and vergence assessment or beyond accommodation and vergence therapies. The management for this patient is completely different, where the priority of management goes to, stopping the progression of keratoconus with respect to, giving appropriate correction in terms of contact lenses or C3R surgeries. Those are the priority that has to be taken into account before binocular vision assessment. So.
Okay, thank you so much. This next question will take, what are the bare minimum sessions we should advise to the patient when they are coming in for the in-office therapy to see significant change in symptoms? Mr. Divakar?
Yeah. So the in-office therapy, bare minimum of sessions, I would, it depends on the severity of the case. Like example, what I presented, the second case, it is like a moderate case of convergence insufficiency. If the same case, if I had seen a severe case where the near point of convergence was at 40 centimeter itself, you're seeing a break point, NPC is too much receded, positive fusional convergence is very much poor, facility is like 0 cycles, not even able to converge at all. So for that case, I would have taken it for a pretty longer period of time to normalize. Whereas a mild to moderate, a 1 month of therapy and a moderate somewhere close to around 2 to 3 months of therapy, and a severe case would require at least 6 months of therapy. So this is what I'm talking about. If they're able to come at least 5 days a session, 5 days a session for a therapy, or 3 days of in-office therapy and 3 days of home therapy, a combined therapy sessions which can be done. This would have been, depending on the mild, moderate, and severity, it's going to differ. Say this case which we presented, I would have taken at least 1 month to 2 months to normalize the all the parameters, and then slowly give a tapering dose of therapy. So instead of calling in every day, so I would have started calling alternate days or twice a week or then once a week, and then associated with that, give home therapies along with that.
Okay, thank you so much, Mr. Divakar. Okay, we'll take the last question. Okay, they've given a case like a 21-year-old patient complaining of headache and uneasiness. So on binocular vision assessment, all the parameters were normal apart from Virgin's facility. So what are the therapies you would recommend? Ms. Namrata?
So definitely I would work on all the Virgin's exercises which would work in improving the Virgin's facility. So whatever we have discussed throughout this presentation, so all those will be definitely added on basically to work on Virgin's facility. So definitely with those aspects, we would work on the therapy part as such. So would like to add anything from your side?
Yeah, those are the ones which are required for Virgin's facility. So these patients will have difficulty in converging and diverging. So simple exercises like a HART chart, even though it is for accommodation, it can also work on convergence and divergence. So when you're looking at the near chart, you're binocularly I'm talking about. So when you're looking for near, you're trying to converge, and when you're looking for far, you're trying to diverge. So such type of therapies you can incorporate and then slowly work on trinaglyphs with a larger aperture, and then go towards the smaller targets with dual polarichrom, where we can use the top one, we can use the lesser demand of versions, or higher demand of versions at the bottom one. Or the top one, we can have a convergence demand, and the bottom one, we can create a divergence demand. Or I can introduce a flipper here. Most of us, we use this vergence flippers, which is like anaglyphs. Anaglyphs, you usually get red and green. So you get red and green flippers as well. So red and green flippers is one side, you'll have a red and green. And when you flip, it will become green and red. So you can train convergence and divergence simultaneously with those. So those are called the red-green flippers. So can be used. And you'll also get these type of flippers in Polaroids as well. When you're using a vectograms, you can use it. Yeah, those are the therapies which can be used in Virgin's facility, improving the facility.
Okay, thank you so much. Sakina, are there any questions on the AP?
No, ma'am. No.
All right, then I think we are good to end the session. Thank you so much, Mr. Divakar, Ms. Namrata, and Ms. Nikita for giving us your valuable time and participating in this webinar. I would also like to thank Ms. Bhavya and Ms. Sakina for all the backend support. Thank you so much. We'll see you in the next webinar now. Thank you all. Yeah.
Thank you. Thank you.
Thank you so much.